All right. Can everybody see my slides?
Yes.
All right. And I see an okay for recording. Okay, so today I'm going to be focusing on some of the ethical challenges. I will refer to some of the legal aspects as well and our general clinical duties to report. I'm going to be presenting two cases today. One is going to be focusing on an elder abuse and neglect case. I'm going to talk a little bit about duty to warn, duty to protect. For those of you who are in psychiatry or about to go into psychiatry, kudos to our M4. I'm going to talk a little bit about the Tarasoff case and how that has launched some of the additional needs for protections outside of the original scope of the doctrine. We're going to talk about duty to report on three different elements of abuse, neglect, and exploitation. And then I have a really interesting animal and patient case that was brought to one of my consults back in April that has created some interesting controversy. And this is a way to think about how we might improve state legislation to accommodate the needs of our animals and patient welfare. So just to start out, I know that these two slides are particularly busy because of the case study, but I'm going to be giving an overview for those of you who are on that are not driving that can read the details of it. I'm just going to give a little oral background to this particular case. This was a 74-year-old individual that has been in and out of the hospital. He has a history of schizophrenia and diagnosed with bladder cancer a few years back, treated with surgery, chemotherapy, really had a difficulty with the chemotherapy in terms of side effects. It would trigger a lot of the psychoses. And after a while, he refused a second surgery and eventually wanted to actually stop the chemotherapy altogether. He has a wife and a 55-year-old daughter. And because of the cognitive decline of Mr. Cox, his wife has been the primary home caregiver, along with a team of care managers, social work, primary care nurse, and a nursing aide. And he's been verbally abusive, waxes and wanes in terms of cognition and the ability to actually talk about his wishes, and has been pulling out his catheter quite often. He's had reoccurring UTIs, and based on a physician's report as well as his care team, he has been in a lot of pain and agitation. And so the nurse and nursing aide mostly been taking his catheter, making sure that he was getting his medications during their stay. But the wife continues to argue with them and does not want Mr. Cox to have pain medication. In fact, she's quite verbally abusive to the care team. And this individual has been really central to Mr. Cox's healthcare over the past 30 years. Between his psychotic episodes and managing and helping him manage his treatment for schizophrenia, now she's in this predicament of being a caregiver for these other things at home when the care team isn't there. And she's been very resistant, and possibly the care team has questioned her own ability to make decisions. So Mrs. Cox argues, insists he doesn't need that much pain medication. He's fine. But the care team is really, really concerned that he may not now be receiving his antipsychotic medications. And they are extremely concerned about his acute and chronic pain management when they're not there. So they're frustrated. They are experiencing burnout, moral distress. All of the signs are there, and have been quite abrupt with Mrs. Cox because now they're questioning whether or not she's abusing Mr. Cox, or is this a case of neglect? And so this case, and actually there similar cases have been written in the literature. In fact, I use the Mr. Cox and Mrs. Cox because that's been a case in the literature. I changed the name for purposes of privacy for our real patient and wife. But these are some of the questions that our ethics consult posed. Mr. Cox refused further treatment, but at the time of his decision, did he have the capacity? And this was a concern because there was no indication in the medical record, there was no indication from the care team whether or not his capacity at the time of his decision making and continuous decision making as a process of consent was even considered. Should his capacity be evaluated at the time of decision making, simply because he has a history of schizophrenia? And one of our care team individuals was grappling with the stigma that she had with this particular patient and said, I don't want to just assume that because somebody has a diagnosed mental illness that automatically we should start saying they don't have capacity or we need to look more into capacity. So she said, we were concerned of even approaching that question. And this was the first time that I had experienced a consult where it was a healthcare team that just was really cognizant of bias and stigma associated with mental illness, but then didn't consider the actual implication of not examining capacity. Mrs. Cox, the current primary decision maker, we questioned, does she have a right to refuse dosing of pain medications? Or is this abuse? Is this neglect? What actually would this fall under? And actually, what is her motivation for this refusal? And so in asking her directly, it was the constant fear that he was not going to be alert, that the pain medication made him sleepy, that he would be out for several hours, and she was unable to gauge how he was doing. But at the same time, we were also concerned that she had been so emotionally distressed and impacted by a long life of caregiving. Our care ethics, not just our principle-based ethics, but our care ethics, really wanted to understand what it was like for this individual to experience what she had experienced. And it came down to, yes, this is an honest case of neglect. There wasn't an intention to do harm, but yet this individual was getting neglected in the sense of not acquiring the medications that he needed. And so I'll give a kind of overview of some of the considerations we examined before giving kind of the end to this case. But we examined the basis of refusal rights, and we wanted to understand the levels of autonomy or self-determination in this family unit, as well as the care team, and making sure that do they and can they enact what is in the best interest, or should we be examining best interests, and to what extent. We also looked at bodily integrity and the amount of physical and emotional pain that this patient was in, to the point where the multiple UTIs, trying to remove his catheter at several points, his bodily integrity and ability for him to find comfort was just unachievable. And the care team, doing their best during when they were there, knew that every time they came back, he kept on declining. There was an insistence that Mr. Cox and Mrs. Cox stay in the home. And so it wasn't an opportunity to have 24 hours care. And so the balancing of, trying to have that autonomy and the bodily integrity along with home care was becoming a particular challenge. There was also this concern about privacy. And in fact, Mrs. Cox said multiple times, you're invading my privacy. I should have these rights. I should be able to manage my husband's care the way that I see fit. And so that she felt that this was a violation of her privacy, and that the argumentative nature and the constant battling back and forth was leading to what she was feeling as battery, if not assault, verbal assault from the care team. And so we also looked at the doctrine of informed consent and the process by which informed consent was offered or not offered throughout the entire process, and the waxing and waning of capacity for both Mr. and then Mrs. Cox. So when we looked at, from a legal standpoint, what are our obligations in terms of a set of recommendations? What are the care team's requirements from both a legal and ethical standpoint? We looked at the exceptions to informed consent as well as the issues of abuse, neglect, and battery. Emergency is typical where you can violate privacy, that you don't need it necessarily informed consent until a person is stable. This was not an emergency situation, so we couldn't follow that exception. Involuntary mental health treatment when an individual's danger to themselves or other people. This is like the historical view of TerraSoft, of the TerraSoft case, where at first glance, it seems as though this has to be an immediate imminent harm. And so we're having to weigh, is this an imminent harm in which we may have to remove the patient from the home because of potential harm to oneself? But most likely, this was a case of a neglect or elder abuse case. And then, of course, the cognitively aspects where individuals unable to make decisions. Here you have a patient that was not able to make decisions. The wife was trying to, at least intentfully, try to help in the best interest of possible, but she too was cognitively declining due to a number of factors, including immediate stressors. So these didn't really fit what you see on the surface of some of these exceptions to immediately act. And so we went to more of the two ethical and legal concepts of a duty to warn and a duty to protect. And part of that duty to warn is not just simply alerting the healthcare professionals, alerting the care team that there is a danger element to this patient's care. But there was also a duty to warn the patient, the wife, recognizing that there are harms present that have not been addressed. And despite healthcare education, trying to manage pain, trying to manage the antipsychotic medication at the time, the care team said, we have exhausted all of our resources. And now, do we have a duty to protect? And in that duty of protecting the patient and the patient's interests, do we have also a subsequent duty of reporting? And so we took a deeper dive into this case. We did revisit the historical landmark TerraSoft versus Regents of California. And there were two rulings in TerraSoft 1 and 2. And historically, the TerraSoft case really focused on an individual. It was Omajit Podar that was threatening Tatiana TerraSoft, a co-ed, and basically was in this love relationship. At least he thought he was in love, and basically threatened Tatiana TerraSoft. And he was seeking care from a psychologist at the time. And the psychologist, knowing that Podar was wanting to harm Tatiana TerraSoft, questioned their obligation to either protect confidentiality, which was kind of the historical norm, or do we have a duty to warn, duty to protect, duty to report? And unfortunately, Podar killed Tatiana, which led to this case. And when we examine typically suicide and homicide, TerraSoft is more clear, where there's this imminent harm present. You would have an obligation. If we know that there's this imminent harm, we have an obligation to intervene. But over the years, 1980s, 90s, early 2000s, the TerraSoft has been questioned in terms of what other ways are we obligated to protect and to report. And this element of foreseeable victimization and foreseeable harm has come in. So children, elderly, in terms of abuse and neglect, have been under the literature of Tarasoff should, and in some contexts, some legal jurisdictions, some state jurisdictions applies, drug and alcohol abuse, suicide, and homicide. It's this first part of abuse and neglect that can be kind of the gray zone in ethical and even legal deliberations. And so when we look at this concept of imminent harm and vulnerability, we typically do see the definitions of abuse of both of child and elder. But the terms of abuse and then subsequent terms like neglect and exploitation really are questioned under Tarasoff, because if there isn't imminent harm, but foreseeable harm, imminent meaning that with most certainty this is going to happen. Foreseeable harm is there's enough pieces of evidence that it is likely a harm is going to be presented. Child abuse and elder abuse, in not all times, but in many jurisdictions, there is enough physical evidence, or at least verbal evidence that that abuse has taken place. So spiral fractures, bruising, things like that. Where it gets tricky is where there's a lack of that evidence. And so when we look at the different types of abuse, physical abuse, sexual abuse, we're going to get into exploitation, the emotional abuse and abandonment. The emotional abuse has become more of the gray area of how do we actually prove that, especially with individuals that are cognitively declining or ultimately lack capacity even to verbalize that particular abuse that is going on. And so this particular case, yes, the wife was neglecting essential pain management. It was very difficult to prove other than some of the comments that she was making. And there was more of evidence of the emotional abuse in the comments she made rather than the physical abuse, other than this patient still was not getting that pain relief that he needed. And so this case actually went before a medical panel in terms of, is this abuse or is this actually neglect? Because it was kind of in both realms. And physical neglect, passive neglect, willful deprivation, and emotional neglect are oftentimes a challenge to prove. I've had cases where individuals have been ethics consults where individuals were actually tied up at home on chairs so that they would not leave because they had Alzheimer's or dementia, and you could see the rope burns in their wrists and so forth. And so you would have that more visible indication of that neglect. Or if they were not getting adequate nutrition, healthcare professionals, you guys can identify when somebody's not getting the adequate sustenance that they need. When it comes more of that passive neglect of willful withholding of care, including medications, it becomes more of a challenge to prove, especially in the court of law, unless there's clear evidence, medical evidence, or the person is actually verbalizing that, yes, they are withholding food, shelter, clothing, medications, and so forth. And so it was a clear indication that this individual still was not able to secure the things that he needed. And it was clear from the verbal abuse that was going on to the care team that at minimum, there was emotional neglect going on here. And so the last category, which this did not come into this particular case, but I want to bring up, is the exploitation element, unlawful or improper act of a caretaker using adult or adults' resources for their own benefit. These are the more clear cases that I have seen in adult ethics consults where we have questioned abuse, neglect, and then exploitation. It's the person that takes the Social Security checks, unfortunately, and are making medical decisions in order, quote unquote, to sustain the life in order to continue getting those checks. And we've actually had patients' families verbalize those things. But the actual neglect and the foreseeable risks have been more controversial in terms of proof and also making the best decisions to make sure that patients and their families are cared for. So this element of foreseeable risk, which is embedded in even the traditional TerraSoft law, has become more, I would say, depending on your state and local jurisdictions, has become more of a critical concept that we're taking more seriously. When we don't have enough evidence of imminent harm, we are then looking at this foreseeable risk, right? So the risk of hazard, harm to a particular individual, of people in the care environment, whether at home, hospital, nursing homes, et cetera. And so here are some examples based on some of the consults I've had, what's in the literature. So for example, a family member who's normally responsible for driving, their patient, their loved one to doctor's visits is intoxicated. Patient doesn't have a doctor's visit today, but you're concerned about the general welfare of the individual. Imminent harm would be if that person is actively intoxicated and planning to get in the car, turn on the engine, and have that patient right there. Under the law, we'd say, done, cease, we're taking the keys, you're not taking this patient to their doctor's visit today. There's an imminent harm, we have a clear duty, but then healthcare teams are trying to say, what then is our duty to warn and protect when there's these foreseeable risks, when we know a family member, a care struggling with certain things, but there's not an imminent harm? Are we required by law to act? Are we required by ethics to act? And it becomes more of a gray zone in both the world of the legal jurisdictions, but from an ethical standpoint, if there's something amiss, if there's some type of maltreatment that you suspect, you should, from an ethics standpoint, have that duty to warn and to protect and even report. Imminent risks, as I mentioned, are more clear-cut cases, are definitely have been historically wrapped up into our legal teams, and if you have that evidence, that definitely it comes into play. Other foreseeable but not imminent risk, negative attitudes or inappropriate comments directed at you, the healthcare professional or the patients, comments that give you the sense the consumer is not being properly cared for, like, I don't believe in pain medication. This would fall under a foreseeable risk. And so documenting these comments, the behaviors of caregivers, including family caregivers, can lead to an actual understanding that this is possibly a neglect, if not abuse situation. Other things that I've seen, environmental hazards, hoarding, bed bugs, animal feces, et cetera, in home environments where there are foreseeable risks to that particular patient who's supposed to be taken care of. And so a duty to protect, a duty to report, even if what comes out of it from an investigation from adult protective services, child protective services, healthcare professionals, if the outcome is like, well, the individual is still safe, but we're going to monitor, at least you fulfilled that duty to try to protect and try to make sure that you're reporting the best that you can. We have had cases of home care visits where our care managers have observed behaviors of family friends who have been intoxicated, handling firearms visibly in the face of caregivers as well as patients. And so a lot of policies that are emerging, particularly in home-based care and community-based care, is if you see something not right, report it. So why are these duties of warning and protecting really an ethical issue? There's so many elements to this. First and foremost, err on the side of caution. We err on the side of caution out of respect and dignity of the persons. And it may not just be the patient or the consumer. It may be the family member that is going through something that we need to do a little bit more investigation of. Our professional moral obligations to address these risks and hazards, to create safe environments, to educate individuals about safe environments and why safety is related to health. Sometimes individuals don't recognize that environmental features do play into their own health or the health of their loved ones. That preservation of the therapeutic relationship and goals of care. This is a care ethics approach. It's not just simply autonomy and avoidance of harm and your core ethical principles. It's also about the relational aspects, the care aspects, fair treatment of persons. That we're seeing an emergency or emergence of more policies because we want to make sure that there's consistency, that there's fair treatment of persons, that just because somebody has a particular appearance or their home has a particular appearance, that we're not going to make judgments. We're going to be acting in ways that are minimizing those harms, respecting the dignity for all persons, regardless of what their living situations and family environment look like. And then, of course, those avoidance of potential or foreseeable risks in the legal landscape or those imminent harms that you do see. One of the acronyms that we often teach our students, teach healthcare professionals about exceptions to confidentiality, but also in grappling with this notion of foreseeable risk and not just imminent risk, that suicide, abuse, victims under the duty to protect or duty to warn, so your suicide, homicide, the traditional elements, epileptic patients and impaired auto drivers, and diseases that you're obligated to warn and report. And so that abuse, current legislation is trying to expand abuse into other elements of exploitation as well as neglect. It depends on the state of what definitions are they including under this umbrella of abuse. Ohio is very much a state that, depending on your jurisdictions or your probate courts, that neglect is very much part of that umbrella of abuse. And in this particular case, we actually did challenge. We went to probate. We challenged the guardianship of Mrs. Cox. She was significantly declining emotionally, mentally, cognitively in her own realm. And so what was best for the best interest of both the patient and Mrs. Cox was to get her some support as well as have temporary placement in a nursing facility for Mr. Cox. Unfortunately, Mr. Cox had declined quite rapidly, and it was about a month and a half, he actually passed away. Mrs. Cox did remain in the home. I didn't have any follow-up after that, but in the last month and a half of his life, he did receive proper care, pain management, and Mrs. Cox had visiting rights and so forth, despite the fact she was pretty upset of the whole situation because she did want him to be at home with her. So in looking at another element that came up in this case that some of our care team was concerned about was the violations of privacy. And even when Mrs. Cox insisted that it was a violation of her privacy and Mr. Cox's privacy for the healthcare team to continually to come in and manage the medication and keep on questioning her. She did not want to be questioned. It was clear that there was a harm present, and the courts agreed that that violation of privacy, violation of informed consent, transfer of care to a nursing facility was deemed appropriate and ethically and both legally appropriate. And so what our findings from this case was that basically all covered professionals who learn of suspected abuse, including that not just the imminent harm, but the foreseeable risk or foreseeable harm while engaging in these types of activities, collect the evidence, document your findings. Like I mentioned, the more imminent level, it's a little bit clearer than the foreseeable risk, but include um, conversations that you have. Those conversations with Mrs. Cox, when they were documented, was very, very effective in making sure that Mr. Cox was okay. Remove suspected abusers from the victim. The court of law will determine whether there's intent or not. And of course, it can be difficult to prove intent. Report suspicions of abuse or neglect, provide findings, and err on the side of caution, even if it turns out that it isn't not a case of abuse or neglect or exploitation, that having that conversation with the patient and the patient's family of how you as a healthcare professional view this situation, you're disclosing and being transparent about your obligations to report, just so that that there is some knowledge that the person is being cared for it appropriately. It is really important. When actions are done without disclosure or being transparent, it can lend itself to more aggression, more feelings of the caregiver, in terms of their feelings of being abused by the care team. And so being more transparent, being more upfront is really important. This particular care team with the two care managers did talk to Mrs. Cox on a regular basis, despite her anger, despite the fact that she was very resistant to many things. They were always transparent every step of the way so that she was made aware. In terms of her own cognition, the physician that was in charge of Mr. Cox encouraged her to consult with her physician, but the first and foremost was making sure that he was okay. For those of you who are very familiar with adult protective services, this is typically 60 and older. We did consult with adult protective services, but it depends on what county you're in. Sometimes adult protective services can be really supportive and help, and other times their caseloads are so extensive that they will provide advice and make those connections. We actually worked with the hospital system, the direction home agency, as well as probate directly. But oftentimes APS was part of that process because Mr. Cox was obviously over 60. Where I do see an ethical and legal conundrum is intimate partner violence, abuse, and neglect when the person does not qualify under the jurisdictions of adult protective services. So individuals that are 18 to 59, it can be a challenge. It can be a real challenge, especially when you see abuse occur. Now, under jurisdictions in which a person, the patient has mental health issue, a disability, a way to actually protect them is through through probate, but also through particular agencies, including Medicare, Medicaid. But it still can be a challenge, particularly when there are issues of partner violence and not so much medical abuse and medical neglect. And so this is just some recommendations for what you do. Making sure that if the person has the ability to make decisions, have the capacity to, it's not necessarily that they're feeling as though they have the power to, but in many cases, if they don't have a lack of capacity and they are able to at least cognitively make decisions, just do the best you can in working with them, getting them the services that they need, support services, safe housing, and so forth. Know those services so that this population, those who are adults that don't qualify for APS or Child Protective Services, and who are not impaired in a way that we can enact special protections through the courts of law, there's a gray zone. And there's a gray zone in which individuals are not getting the support that they need. Children, of course, parents and guardians were suspected of abuse or neglect. I didn't present a child case today, I can in the future. We have several of those, but I can talk more about that in the Q&A. States are required to have a child abuse and neglect prevention program, and it's a federal requirement for this. The federal definition includes a recent act or failure to act on the part of a parent or caretaker, which results in death, serious physical or emotional harm, sexual abuse, exploitation is under that definition, or an act of failure to act which presents an imminent risk of serious harm. Problem with this definition is the word imminent rather than foreseeable. And so there's critique. There is academic critique. There is clinical critique that we need to be more cognizant of those foreseeable risks, monitor and make sure we're documenting those in case a state or a local jurisdiction only focuses on the imminency of an issue. And looking at CAPTA, there is not a federal requirement for a parent or legal guardian to provide any medical service or treatment against religious beliefs. And just keep in mind that 31 states, civil child abuse reporting, there's an exception to the definition of child abuse and neglect for parents who choose not to seek medical care. 16 states authorize courts to order medical treatment for a child, including Ohio. So there is variability from state to state in terms of child abuse, neglect, and also the adult population of the non-adult protective services population, 18 to 59, where there's different court jurisdictions of protections. Making sure that I keep on time, I do want to bring up an interesting case in an animal abuse situation. Again, here's the longer case study, but I do want to describe this. This came up in April. This is one of my consults in April, and I am still grappling with this one. And here's the background. We had a long-term care consult of an individual who is under 60. She has bipolar disorder, PTSD, very abusive relationships, a whole history of abusive relationships, back to her parents even. And she was basically, her former partner set her trailer on fire, leaving her unhoused. She had no clothing, she had no resources, and so she ended up living with her brothers. One brother in particular is very abusive, verbally abusive to her, but actually abuses the dog that's owned by the other brother. The other brother is always gone. He's on business trips quite often. And so it's mostly this woman and her other brother that has been abusing this animal. So care team goes in there and basically they interview her because she has been not only just not able to focus on taking her medications, but she seems really distraught. And so they interview her, and she indicated that her mean brother has cancer, has been hospitalized on and off, but comes back and when gets into the house, starts verbally abusing her, and then starts kicking the dog. And she feels unsafe. She feels safe at her brother's home, but unsafe when the other brother is there. And so the care team said, okay, we need to work with you to get you out on your own. But a care team member actually presented this case, actually asked for a formal consult, said, are we obligated to report this animal abuse? Because we have kind of details about how this dog has been kicked. And so they report it to our ethics committee at Direction Home. And this came up of, if this is reported, she felt enough threatened that she would feel unsafe, that the brother would then know that it was her that disclosed this and do harm to her. And so the question was, to whom do we have a duty to report? And it was interesting because in 2021, Ohio law now requires that if you have any observation, if you have any credible statements from individuals, you have an actual duty to report, okay, that animal abuse that is going on. You're not obligated to investigate it, but you actually have a duty to report it. And so here's the legislation here, basically the policy and practice guidance document. But Goddard's law in the state of Ohio takes animal abuse really seriously. And then this House Bill 33, signed by Governor DeWine, became effective. And so any social service professionals, healthcare professionals, if you have knowledge that an animal is being abused, you have a duty to report. Well, this care manager and the care team are like, but if we report this, and they do an investigation, then she can be potentially harmed. So what do we do? What is the, what do we do? And so they were told by law that they have an obligation to report no matter what, because if you don't report it, it could result in civil penalties. And so what our ethics committee did was actually write the legislators and say, hey, there's a conundrum here that we need to figure out. Yes, we understand we have a duty to report about animal abuse, but when somebody may be in jeopardy, a patient, person that we are responsible may be in jeopardy due to potential harm in the home, foreseeable risks in the harm, where are our obligations? And at what point do we actually report? And so we asked, do we follow the law in an effort to protect the animal, or do we protect the patient? And does it have to be an either or is there some middle ground? So I wanted to pose this to you guys, knowing, in the human world about abuse and neglect, but now things are getting a little bit more complicated. And, when we are confronted with this, is there better ways that we can improve legislation, improve our obligations, both legally and ethically, when these type of situations come up? And so I'm just going to pose that out to the group and any other comments that you guys may have.